This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's lexipol.com. Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and one of the things we try and do is keep up with the news as it happens. If we need to bring in an expert, we can do that to talk about events that are unfolding before our very eyes. Obviously, there is a lot going on out there in EMS land at the moment. And today's topic is the joint statement on EMS performance metrics beyond response times. And who better to join me than returning guest, good friend, and now person with a new shirt on, Matt Zavadsky. Matt, well, welcome back.
Thanks, Rob. Always a pleasure. Never turn down an invite from you, because if it's not necessarily educational, it's certainly entertaining.
Well, we edutain here as much as educate, and you know that. So, of course, for those, once again, we are both an audio and a video podcast and a vodcast. You can catch us on YouTube. You can catch us also on all the places you get your podcasts. And so for those watching, you will see that I wasn't joking. Matt now has a new logo, a new backdrop. Obviously, we know Matt has moved across to the PWW advisory group. You must be, 30 days in? How's it going?
It's almost 2 months, actually. Yeah, May 15th. So it's been a couple months and just amazing. The work that these folks do and the part that I get to play in that and the things that they're doing around the country, it was thought of being essentially what we were able to do at MedStar, and taking that experience and that innovation and now helping agencies and communities across the country do the same thing. And that is exactly what it's turning out to be. And it is exceptionally rewarding. Obviously, the folks are fabulous. The partnership between PWW and EMSMC is very synergistic. In fact, we're just now having some discussions about publishing quarterly EMS indexes related to revenue cycle costs. Much like ESO does for their clinical metrics,
Yep.
We're going to start releasing similar for financial metrics for benchmarking. So it's a lot of fun.
It's exciting, and look forward to hearing all about that. We're going to talk about some more PWW in a minute, because this is germane to the topic, and that's some of the sessions that I've heard Doug Wolfberg particularly deliver in California, but we'll come back to that in a minute. And so, joint statement on EMS performance metrics beyond response times has come out. There is a ton of organizations that have signed up to it, which of course is the first thing. These days, we really love it when we can hunt as a pack. I mean, I'm not going to list them all, but just pick out some of the big signatories if you want to do that.
Yeah, and as your viewers and listeners may recall, it was 2 years ago that many of these same associations did a joint position statement on light and siren responses and reducing those. And this was a logical extension of that. So, Rob, what we were able to do is, as you collaborate with leaders, it becomes a little bit easier to collaborate, and you can pick thornier topics to collaborate on. So the collaboration for the light and siren paper was interesting and very rewarding, and resulted in a phenomenal statement, and then a bunch of work by the National EMS Quality Alliance and literally 50 or 100 EMS agencies across the country who really took that to heart and implemented programs to reduce light and siren responses. You see that in the AIM-High benchmark survey. You see that now in some of the NEMSIS data that's coming out, and that's just sound public policy. So we built upon that relationship and said, okay, let's pick another perhaps more thorny issue with respect to quality metrics and performance metrics. So we invited the same group who were involved in that first joint position statement. But because we knew that this would be a little bit more far-reaching, and quite frankly, we wanted policymakers and elected officials and people who actually monitor things like EMS system performance, or who may contract for EMS system providers, to be involved in this process. So we added really one key group, and and that was the International City County Managers Association, ICMA. And the ICMA is the premier association for city and county managers internationally. And we extended the invitation to them, and they, without hesitation, said, "What are you going to be doing?" "Oh, absolutely, absolutely, we want to be part of that because of the EMS crisis. We really want to know how should we be evaluating, and quite frankly, the next logical step is how should we be designing our EMS systems for quality." So they were a nice addition. The Center for Patient Safety, nice addition to this process. So the American Paramedic Association was new this year, so to this project. So it was really nice to have that very diverse group of folks involved in this process.
Oh, I want to stay with the International City and County Management Association because they are classically non-EMS, although you've already established the linkage to it. But if you're a city or a county manager, probably the police chief and the fire chief work at your pleasure. You have the responsibility to, as I would say in the UK, commission or to purchase emergency services if you haven't declared it an essential service and are therefore funding it yourself. We know there's not many of those around at the moment. So therefore you are instrumental in ensuring the coverage for your citizenry, and you're not the EMS chief. You are actually the person sitting over the top of that. And so I think this is huge, Matt, to have these folk and have their signature and their letterhead and their weight and their support behind this, because ultimately those guys, city, county managers, etc., are the ones that are recommending to their local governing bodies, their elected officials, this, Your Honour, Mr. Mayor, whomever, is what I suggest as your administrative professional, the thing that we do. And therefore, I think that carries a huge amount of weight.
Yeah, and where it started, Rob, was in the discussions and through PWW and through the Center for Public Safety Management and other organizations. More and more, these cities and counties who are evaluating EMS systems and making huge public policy decisions and investing hundreds of thousands, if not millions of dollars in taxpayer funding to gain a minute or two or three in response times. And we really wanted to bring them in, and they wanted to be part of that because they said, we need to stop the madness. We're evaluating the performance of an EMS system based on metrics that have zero impact on patient outcomes for 95% of the calls. And why are we doing that? So
Yep.
They really wanted to be part of this process. And now I know that they've planned now that this is out officially, they've planned a series of educational sessions for their members and publications for their members built on this concept of a balanced scorecard approach to system design and system assessment and system improvement. It's not just about the response times because,
Nope.
again, not a lot of correlation between response times and patient outcomes. In fact, some would say no correlation.
For many years, I've had that slide with the Ricky Bobby on it, the Ricky Bobby rule, if you're not first, you're last. And, the realization in the UK many years ago that, if you have an 8:59 response time and you arrive in, 9 minutes and the patient lives, that's a failure. And if, it's craziness. So let's park response times for the second, because of course, what the letter does is also give some examples of some of the things that we should be looking at. And hopefully, when this letter does the rounds, and of course, we're going to put it in the show notes. It's done the press today. I've seen it in every trade magazine. Every association has published it today, which is good. But examples of the domains and the things that we are looking to measure. And I'll just sort of start throwing some things around, and we can talk about the relative values of measuring these things and versus just the fact, did we get there in time? Or did we get there inappropriately or appropriately in time? So the things in the clinical domain, we're looking at out-of-hospital cardiac arrest. We're looking at STEMI. We're looking at stroke. We're looking at trauma, hypoglycemia, COPD, seizures, invasive airway management, all good clinical things that should be at the top of the list of the things that we measure. And in this paper, of course, they are.
And Rob, that was by design.
Yep.
And the clinical metrics are way more important in patient outcomes and clinical processes than certainly any operational measures for the most part. So we really wanted to highlight that. And I'll give you an example. So I was recently in a community and they were, all about response times and patient outcomes and that correlation. And I said, okay, it's great that you can tell me what percentage of your calls get a response time in under, whatever minutes. But can you also tell me what your system-wide chest compression fraction is for cardiac arrest? Can you tell me what percentage of your STEMI cases have a 12-lead EKG completed and transmitted to a STEMI center within 10 minutes of patient contact? I mean, those are the measures that make a difference in patient's outcome. And they all looked at me like, do what now?
Excuse me. Yep.
Yeah. So I think that, these 16 associations are saying, including the ICMA, that clinical measures come first. You really have to make sure that, regardless of how long it takes you to get there, are you treating out-of-hospital cardiac arrest patients consistent with current evidence-based research? Are you doing the same thing with STEMI and stroke and trauma patients? What percentage of your multi-system trauma patients that are trauma alerts had a scene time of under 10 minutes? Most systems can't tell you that. And those are the things that, yeah, you can get there in 6, 8, 10, 12 minutes, whatever, but the care you deliver is jacked up 6 ways to Sunday. That's a poor performing EMS system. It doesn't matter whether they got there in time or not.
Indeed, we are healthcare. We have had long debates about the fact of, yes, okay, yes, we're governed by the Transportation Agency. The fact is, we are mobile integrated healthcare. As we've had the discussions, I tell everybody it's not a name, it's a list. Mobile integrated and healthcare. It's all the things that we do listed for you conveniently. And obviously, we therefore need to have the clinical inputs and outputs to actually measure that list of mobile integrated and healthcare by. Something that's been near and dear to my heart, and obviously one of the things that we're working on together, Matt, is looking at capturing the news. And of course, for those that haven't signed up to the PWW news alerts, and what you're doing, of course, is selecting almost the headline of the day, which I enjoy reading. And of course, in the back room, you've got the good folk of Aim High, me and our good friend Rodney Dyke, that are collecting, collating, and sorting all categories of news to do a number of things. One is to share with you, and also is to actually start to create a catalogue of incidents and events that we can share with journalists. And in fact, spoiler alert, I've been speaking to a researcher for NBC Nightly News this week, and we passed them the media tracker. So emsintel.org. If you want to go and have a look at it, you can actually search by category. The reason I'm talking about that, of course, is we're on to the safety domain, and response on lights and sirens is a measure. And we've talked about the good work of Redliner, Jarvis et al. I think we've covered that one. Crash rate per 100,000 miles. Yes, we are still not good at pointing the truck. It's heresy because we don't want to use the D word, but here comes the Rob's soapbox. If we're not the driver, who is, right?
Right.
And so therefore we have to be able to demonstrate the fact that we are safe and skilled in handling our very large vehicles. And back in Richmond days, we had a poster of a Rolls-Royce Silver Cloud and a Ford V10 ambulance, right? And the caption went, one of these is a crew served, or is a $250,000 or $150,000 vehicle that requires exceptional maintenance, and the other one is a Rolls-Royce Silver Cloud, right? And so, the fact is, we are driving an expensive piece of equipment with some expensive stuff and people and patients. Of course, they're the most important bits in there. And the fact is that we still see weekly incidents. I don't use the accident word anymore. Incidents and crashes that could be avoidable, that we just need to be aware of the fact that, just because we may have the lights and sirens on, another discussion, it doesn't make us immune, and it certainly doesn't make us impact proof.
Yeah, no pun intended. And absolutely. So you'll notice that in the recommended domain, safety is number 2 as the number 2 domain. percent of responses that get a hot response is number one in that domain, and then followed quickly by the crash rate. So we saw at MedStar and almost every agency that has gone through the NEMSCO process to reduce their light and siren responses. When you reduce that mode of travel on your responses, oddly, your crash rate goes down. So those are very synergistic measures, which is why they're listed as number one, number two, and then followed quickly by job-related injuries. Because you're driving hot, you crash the truck, two people get injured, let alone folks that might be civilians that got injured. So again, there's a very significant method to this madness to say these are the metrics that matter in quality EMS delivery.
And I think also in the show notes, we'll put in the linkages to the excellent webinar from JP Peterson and the good folk, Dr. Swanson and the good folk in Charlotte, when they talked about their reduction in lights and sirens and the commensurate reduction in vehicle contacts. There was a definite linkage there. And so if you go, yeah, that's not going to happen. Actually, we've got the folk that we can put up before you will go, no, been there, done it, PDSA'd it, tried it, and it works.
Yeah.
So let's move on. Staying with safety, obviously injuries, on the job illness, of course, we need to measure that. And then EMS recall, the EMS recall rate after a non-transport. And certainly, from way back in the day of me responding, it was always the cases we'd actually do a phone call follow-up, particularly on diabetics, after, the intervention non-transport, because we saw the increase, the uptick in next day calls and probably transports. And so that was certainly one trick of the trade that we picked up on.
You'll note, Rob, that we included this metric under this patient safety or the safety metric because as treatment in place models become more prevalent, as federal legislation, state legislation gets passed that facilitates EMS to be able to do that type of patient navigation, baking in a patient safety metric of, hey, if we go to a call and we don't take someone to the hospital, how did they do? But did you die? Yeah, but did you die? And agencies should be doing that. And if you've got a 20, 30, 40% recall rate for no transports, benchmark that to the peer organizations, trend that yourself over time, you've got a problem. And you've got a big patient safety problem. And yes, you got there in 7 minutes for 90% of your calls, but you know what? You're threatening the lives of your patients because you're talking people out of going to the hospital that probably need to, or vice versa. So that's why this shift in public policy and contracting and performance measurement is so important. There was just a system in the south central part of the country that is spending $10 million, soon to be $20 million, to gain a minute on their response times. And you really want to say, you're doing what now? I mean, why are you doing that? That's part of this whole discussion.
It was always the 90% argument. Why can't it be more than 90%? Because you, sir, can't afford to put a paramedic on every street corner. And it's as simple as that. And if you want to, then where are you going to find them?
Exactly right.
Yep. Anyway, Matt, let's just take a second and we're going to go to a quick break and have a word from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
As always, thank you to my good friend Jim Dudley, who is the voice of my voiceover and is also the owner and the MC of Policing Matters over on Police One. And even if you're not a cop, the level and quality of guests that Jim has on Policing Matters is outstanding. If you want to listen to a very senior figure in the FBI or somebody from the Department of Justice at the federal level, or indeed cops in very specialized and specialist positions, go and listen to Policing Matters. I can't talk highly enough about it. So cheers, Jim. But also you're listening to EMS One-Stop with me, Rob Lawrence. And before we go any further, just remember that we are a dual broadcasting service. We are on YouTube and we're also on wherever you pick up your podcast. So please make sure that you like and subscribe. Hit that button. As you know, I say it every time. Every time an episode of EMS One-Stop drops, then you get notified that we are here. So we are talking about the joint statement on EMS with Matt Zavadsky. We've talked about the signatories and the importance of those national organizations and associations that have signed on to it. We've got halfway through the domains and some of the things that they recommend. And these are recommendations. This isn't a hard and fast rule, but actually, we think these are the things that we should be looking at and the things that we should be measuring. Coming back into operational measures, though, Matt, we're now talking about unit hours. And you and I have lived unit hours for most of our operational leadership careers. But for that one person, what's a unit hour?
Unit hour is generally one unit, in this case, let's say an ambulance, staffed with the appropriate staffing on duty and available for a call. So God forbid, Rob, you and I are working together on an ambulance and we sign on the air at 7 o'clock in the morning. That 7 to 8 time frame that we are on duty in the truck, ready to go, that is 1 unit hour. So really, it's, if you think about it, there are, 8,760 hours in a year. So if you had one ambulance on duty for 24 hours a day, 7 days a week, all year, that unit hours, that would be 8,760 unit hours that you produced for the year.
That was amazing maths, but I really don't want to see you and I in the truck. But so we're talking about unit hours produced versus scheduled, or scheduled, depending on which side of the pond you're from. And obviously, it's a measure of what you say you can produce or what you are obliged to produce in terms of coverage versus what you actually do. And of course, there's a number of reasons where you don't do that or why you can't do that. And probably retention and availability is certainly do that again is probably the thing of the week, right? Is that, but of course it's something to measure and identify where we aren't getting folk on the trucks. Mission failure rates, of course, response time comes back here in this particular section, but it's appropriate, right?
It's an operational metric. It's not a clinical metric, and it's an operational. Some would say, we had this big discussion with the group, it's a process measure.
Yep.
It's not an outcome measure, it's a process measure, just like scheduling efficiency. Going back to the unit hour discussion, if you want to staff 100 unit hours for the day, but you can only staff 70, you're going to have issues with burnout, with all sorts of different things and all that sort of stuff. So that's why, especially now today, with a lot of systems actually purchasing unit hours from providers instead of just the previous type of contracting where, hey, we're going to buy 900 unit hours a day from you, and you need to evaluate. So you're paying for 900. Did they produce 900? Did they produce 850? Did they produce 700? What should you really be paying for? That's a reflection in some of the current models for EMS delivery.
Excellent. And within the operational sort of domain, again, recommended, and this shouldn't be recommended, this should be mandatory, quality assurance, QA assessments, looking at all of those metrics and then creating some sort of value judgment in order to encourage performance improvement, in order to identify best practice, in order to identify efficiency, is a key part, certainly within the work that we're doing at Aim High. Benchmarking, QA, QI assessment is absolutely key, just to measure just how well we're doing.
And Rob, this metric refers specifically to EMD prioritization. So
okay. All right.
Advanced systems, they are looking at all 3,000 of the EMD determinants to make sure that a 9 echo 1 really results in high acuity patients with a certain degree of reliability, and that's worthy of a hot response. If not, change it, reprioritize it, make it a cold response, make it a battalion unit only response if it's got a low transport rate. But this is a reflection of literally doing that quality assurance to make sure that you are prioritizing your responses well, because if you're responding to every system, and this was a great conversation I had yesterday with a fire chief, every system does call triage, every system across the country. Some do it by time, which call came in first. Some do it by science. And the people that do it by science are the ones that are going to be able to pull a unit that's 2 blocks away from a baby not breathing call, but they happen to be on an ingrown toenail call, as opposed to allowing the ingrown toenail call to have the same priority as the baby not breathing call, because they triage by time, not by any type of scientific research. So this is an acknowledgement of the fact that you need to QA your dispatch process to make sure that you're prioritizing calls appropriately.
Okay, so now I've attuned myself to that level, that QA sort of category. Of course, what most organizations have is something like an MDRC, a Medical Dispatch Review Committee. Certainly had I enjoyed having Dr. Joseph Pionato as my medical director for 10 years, and this was a annual, if not regular, event where we looked at every last code in order to identify, the dispatch criteria, and indeed, did we need to, for example, add a fire truck to it? And actually, if the evidence says this is such low acuity, we want to hold that truck in the house ready for the high acuity call, for example. And so, those sort of, as we call them, center fire calls were adjusted regularly based on the evidence that was the level of acuity that of the patient cohort that we'd seen in that particular dispatch category. And it makes sense to do that.
Exactly right. And Rob, I want to mention one thing that when people read this, the response time thing, you'll notice that there is a specific measure put into that recommendation. And that measure is from the patient's perspective. I get so frustrated when agencies say, we've got a 4.5-minute response time. Well, you may have a 4.5-minute drive time, but you don't have a 4.5-minute response time, because it takes you a minute to get out the door, takes you 3 minutes to process the call. So when we talk about the response time metric here, it's from the patient's perspective, from the time that they call 911 to the time that a provider is next to them and treating them. And no system that I know of currently does that. But that's, if you're going to measure response times, that's the time that matters to the patient.
Yep.
Not how quickly you can drive there. Not you built, a facility that's within a 5-mile radius of this particular area because that's the drive time. No. If you're that concerned about, response times, don't spend $10 or $11 million on a station. Put your truck on the street corner and eliminate 1.5 minutes of activation time. Because you go from park to drive in 11 seconds instead of park a lounger to vehicle in 1.5 minutes.
We spent a lot of time talking about the goings on in the UK and in Australia and other places, and even as I was leaving the UK, we introduced what was known as the Call Connect standard. The clock starts the moment you go, you didn't even get the hello out, right? It's ding, right. And the clock is running because, quite simply, it's not our emergency.
Right, and I can't tell you the number of people who will say, well, it took you like 20 minutes to get here. And when agencies look at that response, they say, well, no, it only took us 12. No. It took 2 minutes to process the call in the primary PSAP, another 2 minutes in the secondary PSAP, 2 minutes to get. So the patient's right. Your metric is wrong. Their metric is correct.
Indeed. And when you look at a lot of work that these folk that do cover studies do, it's actually about how you improve the process before the wheels get going. That's where the seconds are, not anywhere else. And I'm not getting into a response time discussion, but of course, one of the things I would used to do as a COO is actually say, well, we were below the required percentage, and let's look at how many seconds we were out by, and actually we're in 901, 901 and a half, 901, 9 whatever. So we're talking about 5 seconds we have to find across the month. You don't want to spend 5, 6 million, 20 million quid, English dollars. Sorry for those listening in the UK.
Welcome to the Harry Potter show, y'all.
Indeed, yes. So anyway, time is moving on. Now, this is an interesting section, experiential. Of course, we've both been used to doing patient surveys for a long time. Obviously, their views and obviously where they sit in net promoter scores and in the top boxes and all the other good metrics that you're measuring are important, but also this advocates a number of other surveys as well, which I found fascinating to read.
Yeah, so patient experience surveys absolutely essential, but they can't be conducted by the agency. They should be
Yep.
conducted by an outside organization. But the patient's only one stakeholder. You should be surveying your hospital partners for when you're bringing patients to them, picking up patients from them. You should be evaluating the perspective of the employees, your employee engagement surveys. Why do they stay working for you? Why do they like working there? First response organizations, or vice versa. If you're a first response organization, you should be surveying the ambulance provider if it's not the same agency, and really even dispatchers. So across the board, and the Institute for Healthcare Improvement, IHI, has spent a lot of time, energy, and resources helping healthcare system leaders, including EMS leaders, understand this, fourth and fifth element of the triple and now quadruple or quintuple aim, and that is provider experience. And we need to do everything that we can to help improve provider experience. Just last week, we did the TikTok generation webinar with AMHI, very well attended, now has been watched hundreds of times asynchronously, but asking people, how do they like to be engaged with? How do they like to be communicated with? What's important to them? Can we allow neck tattoos and still have the public think we're being professional and also help our employees feel appreciated? Those are the thorny issues that this position paper says we really need to be asking, because that's where the rubber meets the road. Can we get people in the door? Can we keep them happy? Can we keep them from turning over so that we can have a stable workforce?
So let me do a quick plug here, because the good folk of EMS One were listening to the Aim High TikTok generation lecture, and no sooner had that session, and we'll put that in the show notes. It's obviously via Aim High. I get a note from Greg Fries saying that actually there was some amazing people on that lecture, and we're currently planning, coming up on EMS One, the What Paramedics Want webinar, where we talk about this year's What Paramedics Want survey. And so Tom Wobby, who was a member of your presentation,
What?
is going to come and be, let's call him the junior member, am I allowed to say that, on the What Paramedics Want, because of course we need to be talking to the folk that are on the shop floor dealing with it. And so Tom is going to represent that cohort over on the What Paramedics Want webinar, which is coming up in September. So keep watching, everybody, the EMS One various sites, and we will put that up. I'm going to MC that along with Maria Bierman-Fote and Carly Strong, and from Riggs in California, and also Tom Wobby. So that's coming up in September. Anyway, let's finish with the F word. We have to, and financial, it is in there. And show me the money, Mr. McGuire.
Yeah, and this is one that there was a fair amount of discussion over, because
I can imagine
some of the agencies just didn't know how to start. They were afraid of it. But at the same time, folks like from the ICMA said, no, we absolutely need to know this, because with no margin, no mission, we really need to know. And we don't need to be afraid of the number. We just need to be able to know how to evaluate that number. So being able to assess cost per unit hour, cost per response, cost per patient contact in a way that people can understand. So that way, if you've got a decision to make regarding adding unit hours, and your unit hour cost is, $250, are you going to get a value from adding another $2,000, $3,000, $4,000 a day to the cost of your EMS system to gain half a minute on the response times? Conversely, if you do in your reference medic, if you do something different and you change the system design, which requires you to staff less unit hours, and you can reduce costs, reduce the subsidy that taxpayers are having to pay, and not have any negative impact in patient outcome, that's a logical, financially prudent decision. But you need this metric to be able to know what that is. So we know this is going to be a challenge for some communities and for some agencies. There are resources available. In fact, we published a resource document that people can use to find some resources and some metrics and some examples and position papers and studies that support every one of these metrics that we've put on this paper.
So as we come to the end, I'd mentioned I dropped Doug Wolfberg's name earlier on, and I was in a session at a conference here in California where Doug was talking about the work that he's currently doing, or PWW are currently doing in Alameda County. They're going out for RFP at the moment. The 5-year cycle is up. They're looking for a potential new EMS provider. But actually, the requirements and the must-dos listed within the RFP pretty much reflect what we've just been talking about today. And I think that's going to be an interesting one to see who's going to come forward and actually lead off in this new direction. And I think that's an exciting moment. So I wanted to plug that, because that was one of those lectures and sessions where Doug was describing this, that, you could hear the proverbial pin drop, because people were paying attention to, all of the things and the measures that were going into it, and also the never events, right? Never should this happen events. And I think that I actually owe Doug an article on that, by the way. So I need to put pen to paper on that one as well. But
and I think we're beginning to see that, Rob. A lot of the communities and a lot of the consultants that help communities write these RFPs are finally adopting this. And one of our goals, the 16 agencies that did this, was to give a referenceable document for communities when they're going to go out to an RFP, when they're going to potentially consider system design change. Here's the metrics that you should consider using to evaluate current, evaluate upcoming, whatever it's going to be. But how do you know that the system is working the way that you thought it was?
Right. Final question. So we've got the document in our hands. We've downloaded it. We've read it. We've digested it. If you are the CEO or the chief, what do you do with it?
Yeah, put it into practice. So what our hope is that agencies will see this. They'll know that this is a continuing discussion that now is going to get a lot of legs, because now there's actually a published paper in a peer-reviewed journal, and there'll be coming out another one here shortly, where you, as a fire chief, as an agency head, as a city manager, as a county administrator, as an elected official, you should take this paper, walk right over to the provider's office, whether that's the fire department, whether it's a contract, whether it's a county system, whatever, and say, pick 2 from each category and tell me what yours are, and trend them over the last 2 years in a statistical control chart. And now you can really start to begin to say, yes, the system is working as designed. No, it's not. Costs, you'd start tracking out costs over 2 years. Holy crap, what happened last October where we went outside the upper control limit for the costs and it stayed there? What changed? How can we go back to that to reduce the reliance on the taxpayer or reduce fees? That's the goal. All of us that were on this writing team really want communities and agencies to start tracking and reporting metrics that matter in terms of evaluating your EMS system. And it is not response times.
Well, there you go. That was the perfect summary. It was also the soundbite I'm going to clip for the future advertising. Matt, thank you very much for going over this paper with me. As I say, it's in the show notes. It's in pretty much every trade magazine this week. You can find it readily accessible. Anyone, and we're all connected via various social media pages. I notice it's also popping up on everybody's social media pages as well. So have a look at it. And as Matt says, act on it, because, of course, we want to have a system that's meaningful, measurable, and actually valuable. And so that's what it's all about. And so with that, Matt, thank you very much indeed. And I know you'll be a returning guest, but also thank you again for also taking on the role of Executive Director of Aim High. And so that's another job that you've picked up on. So before we go, talk about that.
Sure. So AMI, the Academy of International Mobile Healthcare Integration, has used the American Ambulance Association for their association management for a long time. The folks at the AAA have a ton of stuff going on, and they're doing amazing work for the industry. And when I joined PWWAG, part of the conversation between the president of AIM High and the AAA and even others was, hey, is this now a logical time if the AAA wants to transition the management of AIM High, if you will, over to PWWAG, we can really have some dedicated leadership, some dedicated resources to drive AIM High even further into the performance-based, value-based, high-performance systems. And Rob, you know that one of the big projects that we have on our plate now coming in September is going to be putting together a guide for communities to be able to do the things that we list out here, how to design a high performance, high value EMS system, and then how do you track the metrics to prove that you have that? And that'll be one of the big projects coming up this fall. So we're really looking forward to it.
Great. And I know the president-elect, and he's going to give you all the support and encouragement you need. So
thank you, Mr. President-elect.
Oh, we weren't meant to say that. No. Anyway, so Matt, thank you as always. You are a national treasure in the EMS sphere. Thank you for joining us. And that's it for this edition of EMS One-Stop. Don't forget, I'll say it again, please make sure that you like and subscribe. All the things we've talked about, not least the paper that we've talked about, are in the show notes. Please make sure you read it. Please make sure you act on it. Matt Zavadsky, thank you very much. This was EMS One-Stop. I've been Rob Lawrence, and until next time, bye for now.